So tonight we have Dr. Dave Margolius, the Director of Public Health for the City of Cleveland, talking about racism as a public health crisis, updates on urban health in the US. 2 weeks from tonight, we'll have Dr. Rob O'Malley talking about science communication and engagement with faith communities. Then we will be into our Darwin Days programming for 2023, which Rob was just talking about a little bit, and we'll have a Devonian Fishes Darwin Days panel on February 9th. February 23rd, we'll have Dr. Brenda Young talking about the amazing biology of the honeybee, and Brenda is at Damon University. And on March 9th, we'll have Dr. Bryce Hand, Emeritus Professor of Geology. And on March 23rd, we will have Dr. Nick Levine talking about what we can see from space. And there is the link, which I'll also put in the chat for you to see what else is coming up, and that will get updated with the April and May talks as those get finalized. And I am going to stop sharing and hand it off to Dave. Go ahead and take it away, David.
All right, let's see if I can successfully get my big screen going here.
There you are, looking good.
Great, well, thanks for having me as now an annual tradition, I think always in January, it seems like. So yeah, happy to be here, and much has changed for me over the last couple of years, and I'm sure much has changed for all folks in the audience. So I'm going to talk about Cleveland Department of Public Health, specifically some of the work that we're centered around, which is racism as a public health crisis. I hope to go through what that means, what we're doing about it as a department, and what we're doing about it as a city, and what we can all do about it. I will try to monitor the chat as well, but feel free to come off mute and ask questions, and there should be plenty of time at the end to ask questions as well.
Yeah,
okay.
I'll keep an eye on the chat for you too.
Thank you. All right, let's see. Okay, great. So last time I was here, we were talking about COVID, and this was a couple years ago now. Ran the COVID hotline. In April of last year, so 3 months or so after I last presented to this group, the job got posted for Director of Public Health, City of Cleveland. And things were going really well at Metro. We were coming out of the kind of scary part of the pandemic and ready to kind of refocus on increasing access to primary care and reducing disparities in chronic diseases and that sort of thing. But a few colleagues and friends sent that job description, the job posting my way for Director of Public Health. And I said, maybe one day that would be great. They said, no, you should really apply now. So I applied, and a couple months later, I was sworn in as the Director of Public Health, City of Cleveland. That's August 1st of this year. The work that I inherited in the health department this is our org chart. We've got 5 different divisions that are covered there. Health equity and social justice, air quality, environment, our administrative wing, and we're building up a new division right now, which is overlap of public safety and health, which unfortunately is a big issue in most cities. How folks are treated in crises like mental health crises, how police interact with health, and that sort of thing. Air quality we are the EPA for air for the county that we sit in. Environment, we do state and local code enforcement of all the health codes. So that includes restaurant safety, it includes following up on lead poisoning cases, pools, tattoo parlors, barbershops, all sorts of exciting, fun things there. Health equity and social justice, it was a new division that we created in 2020 around the time we declared racism as a public health crisis. And that houses our infant mortality reduction program, mental health and addiction, HIV, STI prevention, And then the Division of Health has everything else: epi team, vaccine team, vital statistics where you get your birth certificate, death certificate, lab, and emergency preparedness to get ready for the next pandemic. So that was what the look of the department is. The scope of the challenge for the department is this, what you're looking at here. So this is a map of Cuyahoga County. The innermost white line border is the city of Cleveland. And as you can see, the life expectancy for Clevelanders is generally 10 to 20 years shorter than even our inner ring suburbs. So folks who live just a mile or two away end up living 20 years longer as a result of the hostile conditions of where they live. And we'll talk more about that, of what those hostile conditions look like. So when we say racism as a public health crisis, and this is why we see that life expectancy difference in the parts of the city, what we mean is that Black people in the United States have a shorter life expectancy than white people. So it's 4 or 5 years, and it just hasn't really closed over time. And the reason is racism and not some sort of genetic difference between the races, which we'll go into. So how does structural racism lead to different expectancies in life? Well, first step is structural racism creating segregation. So this is a historic redlining map, which exists for every city throughout the country. The areas that are marked red were marked by the banks as areas that should not be invested in, aren't worth investors' times. The exact language I'll show you here. And many of you have seen that this type of language, but here's a neighborhood that has strong colored infiltration, 55% Negro. It's just, let's see, something about, detrimental change of ownership occupancy from white to colored. And so it doesn't deserve your time of day. And these are actual, documents that have persisted through time. So this is what Cleveland looks like. Most cities in the United States, or I should say all cities in the United States are fairly segregated in this way. So the east side of Cleveland and that crescent, that's C-shaped, are communities that are predominantly Black. Predominantly Black neighborhoods suffered from systematic underinvestment, not only because of the decisions that the banks made for developers, but also what banks have done and what society has done in terms of creating generational wealth. So for every $1 of wealth a white family has, a Black family only has 12 cents. And as you can see, from 1989 to 2019, that generational wealth gap hasn't closed at all. So you've got this system that puts people who are predominantly Black, or creates predominantly Black neighborhoods. People who are Black have 1/8 of the generational or the cumulative wealth of people who are white. And those poverty lines track this pretty much the same as what we saw for those race segregations. And then as a result of all those factors, that segregation creates pathogenic residential conditions. And so what does that mean? So here's one example of a pathogenic residential condition. This is a heat map of where traffic fatalities have occurred in Cleveland over kind of recent time period. And as you can see, the dangerous intersections predominantly are on those same neighborhoods that are Black in Cleveland. And so at these intersections, people are dying at a much higher rate. In the city of Cleveland, we lost nearly 300 people in the last year annual average over the last few years to traffic fatalities. So either car on car or car on pedestrian or car on bike. And the intersections, the neighborhoods just look different. They look like this picture over to the right, where there's poor visibility around those corners. There's not a lot of tree canopy. There isn't anything on the road. You don't even see the dashes in the street to separate it into 2 lanes compared to what you see in the better invested neighborhoods on the west side and in the suburbs. Another example of segregation creating pathogenic residential conditions, which leads to these disparate life expectancies that we're seeing, is lead poisoning. So Flint, Michigan is well known for having a really high rate of lead poisoning. Cleveland's was double that, and it remains double, 2 to 3 times higher. In Flint, Michigan, it was a situation with the water, and it was bad, no doubt about it. In Cleveland, it's all from old homes. And you drive through the east side of Cleveland, neighborhoods that have been segregated, predominantly Black, underinvested, and many of the homes, not all, but many of the homes look like this one on the right here. And you can tell kind of from the street that they're dangerous for any kids to live in, because you see the peeling paint, built before 1978. And so you can see the percentage of children who tested for lead poisoning who had elevated blood lead levels. And lead poisoning is irreversible neurotoxin. So huge problem. So we saw the traffic fatalities. We're looking at the lead poisoning in terms of pathogenic residential conditions. And then this one isn't quite as obvious as how it links to health, but we're all a connected world and can see this in our day-to-day lives. But this map from just a few years ago shows access to high-speed internet by census tract. And so you can see in that red area, the same exact crescency, the same exact map that was designated through redlining, that because of the lack of investments in infrastructure, that folks living in these neighborhoods don't get access to high-speed internet. Even if someone with a lot of money were to live in these neighborhoods, and there are people who do, the infrastructure, the deep cables underground aren't there, so you can't get the same speed and same internet plans. So there's a lot of good data connecting access to good internet and health, and you can imagine how that all plays out with anything from healthcare, patient portal access to remote work, jobs, education, et cetera. Tree canopy, a fourth example. So as I mentioned before, you saw the picture of that intersection, just the degree of tree canopy is disparate between the east side and the west side of town, especially further west, and even more when you compare to the suburbs. The area in the middle is mostly skyscrapers downtown and then the river. But the single best thing that you can do for a neighborhood to make it healthier is plant a tree. So we'll come back to that on what we can all do. So racism is a public health crisis. So what does that look like in words? Policies, laws, processes that differently oppress racial groups. And so we saw that with the redlining map policies from banks, and it has played out in a lot of different ways, which we can talk about. Cultural racism, which is imagery, symbols, media that spread or normalize stereotypes about oppressed races. And discrimination, which we'll talk about how that leads to poor health conditions as well. So discrimination. As you're looking through these questions from Professor David Williams, sociologist at Harvard, see what would you answer to any of these questions. So at any time in your life, have you ever been unfairly fired? Have you ever been unfairly discouraged by a teacher or advisor from continuing your education? Have you ever been unfairly denied a bank loan? So it's possible that you were, said yes to one or two of these options, but on a whole, people who are Black are answering yes to many more of these questions compared to people who are white, and those 1,000 cuts have implications on folks' health by raising cortisol levels, causing excess hypertension, excess heart attacks, excess heart failure, and other mental and physical health conditions. Everyday stressors on a relatively smaller level than those earlier conditions. So you're treated with less respect than other people. You receive poorer service than other people at restaurants or stores. People act as if they think you're not smart. People act as if they're afraid of you. So everyday occurrences for some people more often than other people, and that all those things have implications on folks' health. For folks like me who can look at a list like that and it does not resonate in the same way. We made this great movie called Toxic, a Black woman's story. It's 26 minutes. You can check it out online, and it kind of walks through an unfortunate day in the life. And I say unfortunate because this is a Black woman who in the movie is pregnant and then ends up losing her pregnancy as a result of the chronic stress, and just showing how that stress plays out in folks' health. So how does racism impact health? Structural racism leads to wealth gap, leads to segregation. Segregation leads to pathogenic residential conditions, which I have hopefully illustrated with a couple different maps of how that plays out. Increased traffic fatalities, decreased access to internet, to tree canopy, worsening lead poisoning, and on and on and on. And then as a separate method of racism impacting health, discrimination, leading to reduced access to goods, and then toxic stressors as well. So when I last presented this topic, sorry if you can hear my 5-year-old screaming in the background. When I last went through this topic, I was talking to medical students and med school professors. And hold on one second. I'm
not bothered by leaving.
We're good. So when I last described this topic, I really wanted to emphasize how racism is what leads to life expectancy disparities and not race. And I think by now, most folks are there. It's like, yeah, obviously, this is a, an issue of society and the built environment, and education disparities and things like that, and not how someone is their race or their genes. However, in medicine and in other areas of science, race is still treated as a genetic category. And many folks are starting to move away from that, but it still lingers. And so one example is sickle cell disease. A lot of our test questions in medicine and prompts and research categorizations ask folks, oh, are you Black? Oh, if you're Black, that means, sickle cell, or it could be sickle cell. And the reality is, when you look at the map of people affected by sickle cell across the world, as you can see, there are people who are Black, but there are also people of many different ancestries across the globe here, the Arabian Peninsula, India, Northern Africa. So when we talk about looking for genetic proxy, ancestry works, but race doesn't. Still today, in the American College of Cardiology, if you look at the guidelines for how to treat heart failure, if someone has stage 3 heart failure and they are Black, you prescribe them these medicines: hydralazine 2 pills every 8 hours and isosorbide dinitrate every 8 hours. If that same person identified as white you would be talking about a heart transplant and that LVAD thing that Dick Cheney had, and palliative care. But because medicine is still treating race as a genetic category and saying, oh, there must be some genetic difference because we did a study and hydralazine worked better in Black people. This is still something that's propagated in med school. This is a formula for how we look at someone's kidney function. So there's blood tests called creatinine. Type in their creatinine, you type in their age, you type in their sex, and then everything's pointing that this person has chronic kidney disease, and we should really take this stuff seriously. But well, hold on, they're Black, and their kidney function is probably okay. And the reason that was built in there was they said, well, in general, so higher creatinine means that you have kidney disease. In general, Black people have higher creatinine because creatinine is also in muscle, and Black people have more muscles. And therefore, we should correct using this creatinine formula to do kidney disease and type in they're Black, and then their kidney function is fine. So we know the concept that Black people have more muscles is based on racist tropes and things of that nature. It doesn't bear out in the actual science, and it doesn't make sense because Black is a social construct, not a genetic category. To identify one person as Black, is really a subjective comment. And so, fortunately, finally, in February of 2022, just under a year ago, the Kidney Society of the world said, okay, we're gonna, race shouldn't be in there. So that's good. So one step is done, but there's a lot more work to do. And that type of thing plays out in how people are treated. Here's just one example from a few years back where they looked in an emergency room, people identified white, people identified Black, same presenting problem, a broken bone. 43% of the patients who identified as Black did not receive pain relief in the emergency room, compared to 26% of their peers who were white. And so while it might seem like, oh, who cares if there's a creatinine race coefficient for kidney function, it really matters, because that same assumption, that same wrong assumption that Black people have more muscle and therefore their kidney function is probably fine, plays out to how people are treated for pain. Oh, Black people can take it. Or we don't want to addict Black people, or whatever it is that leads to these outcomes that have major implications on health. So that's how racism impacts health. That's how we make sure to take race out of the genetic equation. So far, as we alluded to, it's often a hard to hear talk with bad health outcomes. But the good news is, we can do something about this. So here are our segregated inhospitable conditions that I showed you earlier. And here are some different things that we can and are doing about it in the city of Cleveland. So for lead poisoning, the city and partners have raised $120 million to help rehabilitate homes that are lead poisoning traps and build new homes. So that's ongoing work and will take a long time, but it's ongoing. There's work being done to make streets complete and green. Complete means multimodal, so protected bike lanes, protected walking lanes, better safer intersections, green meaning more trees. So that work is ongoing. And then transit-oriented development means that we get more and more people less dependent on single occupancy vehicles to get around. And so that's work that is building higher density of homes and businesses around high frequency transit corridors. So where good, reliable public transit that goes every 15 minutes reliably, building density around those areas and removing parking minimum requirements for new developers. So when someone wants to go and build a new building in many of our cities, they're required to build like 3 new parking lots at the same time, which does nothing for transit-oriented development. So those are things that we can change because they're all part of the local code. And then we are working on a citywide plan for broadband connectivity, because this is an investment infrastructure that will have big implications on health. This is the lakefront on the west side of Cleveland, and it's this beautiful beach where you can see all these people hanging out. This is the beachfront, the lakefront on the east side of Cleveland on the right side, and it is a private airport used by or private jets. I mean, most often like business people coming from out of town and athletes in Cleveland. And so not used very often, private airport that the people are not benefiting from. So one of our priorities across the city, and it'll take a few years, but we're gonna close down that airport and turn it into something that looks like on the left, some kind of beautiful park, so that the access to green space is not something that's just in the east of the west side of Cleveland. Moreover, these are the 6 issues that keep me up at night in terms of impacting health of Clevelanders. So Cleveland has the highest smoking rate in the country at 35% of adults. So over 1 out of 3 adults smoke cigarettes in Cleveland. So we're it's believe it or not as much of a racism as a public health issue, but still our #1 issue, because the smoking rate for people who are white in Cleveland is 35%, and the smoking rate for people who are Black in Cleveland is 35%. So we got a big plan on that. We're introducing some legislation to ban flavored cigarettes and flavored vape products. We're doing a tobacco retail license, which means if you want to sell tobacco in Cleveland, you got to get a license to do it, which allows us to enforce all the rules around that. Tomorrow there will be I think tomorrow in the Plain Dealer, so mom, dad, save the Plain Dealer tomorrow. There will be an op-ed for me about smoking in Cleveland, hopefully, so I'm told. #2 is, and not necessarily in this order, but gun violence homicides take 170, 160 people from us in Cleveland every year. And so compare that at this point to COVID, we lose about 1 person, 1 or 2 people a month from COVID in Cleveland over the last 12 months. So maybe 20 people last year, which, every death is tragic, but the severity from gun violence and homicides is 8 to 10 times that. Lead poisoning, as you've heard, huge challenge for Cleveland, getting better slowly, and there's good momentum around it. Cars are a major threat to public health for the traffic fatalities that I illustrated earlier, but they also are the #1 contributor to air pollution in our region, vehicles in general. Overdose deaths from opioids, 200 to 300 a year in Cleveland. And so huge challenge, always a premature death, and entirely treatable, preventable. We just got to get there in terms of the stigma around treatment. And poverty just in general is kind of an underlying risk factor for all of this. So here's what we're doing about it for all these different areas. We can talk more about in the Q&A session. Not typical public health interventions, but they all are very much public health interventions. And that's the work that we're trying to do in the city of Cleveland. And so hopefully what you took from the time is that racism is a public health crisis. And what that means is there is this life expectancy between Black people and white people, this disparity that is not due to race, it is due to racism, and therefore that's a public health crisis. This is some members of our team. That's the mayor off to the left there, and the mayor's assistant that I'm holding up there in between me and the mayor, and some members of our lead poisoning secondary prevention team at our lead walk. So with that, I am at the end of my talk, and I can keep my slides up if there are questions on anything in particular, and then I can take it down so we can look at each other.
All right, great. Thank you so much. And we'll open it up for questions. I see there's already one in the chat from the incognito parents who ask, is the Public Safety Department Police Division receptive to working with the Health Department on the issues that they have a role in?
Yes, yeah, they, you know, everything's about relationships, and I have a good relationship with the director of public safety, and they're excited to change the reputation of their department.
That's good.
Yes, he's a successor to Elliot Ness, right? Yeah, because Elliot Ness, is that the right guy? Yeah, he was the director of public safety in Cleveland in the 40s or something like that.
Other questions?
I have a question. This is Rob Ross. There's a group of cities known as biophilic cities. I don't know if you're familiar with this network that is dedicated to increasing green space in urban areas, and basically to reduce disparity among different populations in the city in terms of their access to green space. And you had mentioned that lack of access as one of the many variables in Cleveland that is impacted by racism. So I just wondered if you're familiar with biophilic cities, or if there's some similar group in Cleveland.
Yeah, so I've not heard that term before, but we are part of a national cohort increasing green space in cities. I'm trying to remember, it's something like Kids for Nature, or something like that we're part of. And the group in Cleveland is called the Western Reserve Land Conservancy. And when we look at the land that the city of Cleveland owns, which happens in a lot of different ways, but predominantly it's through vacant lots. We own, I think, like 38% of the east side of Cleveland. And so this is very much, within our wheelhouse, or within our realm of control to be able to change. And so we've signed on to a program through the Western Reserve Land Conservancy called Clevelot, where we're looking at revitalizing those vacant lots and helping to solve the green space apartheid on the east side and access to green space.
Yeah, that's very cool. And it's certainly outside of my direct expertise, but my understanding from colleagues is that there's an emerging research literature on the positive impacts of green space on health.
Yeah, absolutely. And I might have mentioned it too briefly, but really, I think the number one intervention to improve health in any neighborhood is to plant trees. And that's what the science shows.
Yeah, and I'll note there is another question in the chat, but I'll jump ahead of it and note that we at PRI are working with Prince George's County Schools in Maryland on environmental science related program that's in part funded by the National Oceanographic and Atmospheric Administration, where a part of what we're doing is having students work to measure tree canopy and the amount of trees in there throughout the district. And it's a countywide district that ranges from rural to suburban to urban, and students are involved in the county's climate action plan, or will be. I shouldn't say they are as yet, but that's an aspiration. And I think it's interesting how many of the issues that you talked about, if we address them successfully, not only are we improving public health, we're improving education, and we're better responding to climate change. And that multi-solving approach, I think, it just has awesome potential, and I hope we can get past the resilience of problematic systems. And now I'll I'll let you comment on that maybe, and then
yeah, no, that's great you mentioned that, because the director of sustainability and climate justice for the city of Cleveland is a good friend. We came over from Metro Health at the same time. She was the director of sustainability there, and she will, anytime she's talking about climate justice, environmental justice, sustainability, she mentions health and brings health into it. And so we meet up once a week to kind of plot exactly what you're describing, like how we can continue to kind of talk about these topics together. So
yeah,
more
and
people will
I'll
listen.
note too that Erie County, New York, where I am, where Buffalo is also has their climate action plan, has opportunities for students and teachers to be involved in. And again, this addressing one of these issues cuts across the systems of education and medicine and transportation and infrastructure and cyber infrastructure and so on. And Carolyn's question is, can you speak to any problems from opioids other than death?
Yeah, well, yeah, I mean, a lot of problems, yeah, right, outside of death in any of these cases. What we see from addiction in general, beyond physical problems, beyond mental health problems, is a rise in crime, and huge challenge. So we, are taking a public health approach to it as a city, which was good, because I got there and everybody's like, all right, we're taking a public health approach to this, like, go. Basically what that means is what can we do? How can we move upstream, change the built environment, to reduce rates of addiction, to reduce stigma around addiction, to treat addiction, to decrease the impacts from it. So, and Rob, thanks for putting that link in there. I'll check that out.
And Ingrid's got a hand up.
Yeah, as I was listening to you, I was sort of thinking, what could I as an individual do about this? And I don't know the answer, but one thing that occurred to me is I think I would feel comfortable talking to my own doctor, my primary care physician, about this, like just asking him, say, what is your practice doing? Are you taking any approaches to thinking about the way your staff practice medicine, maybe things they've learned in medical school that were racist. They don't even realize they're racist. But there's new research that shows that it was racist, and there are better ways to do things. And I think my doctor would be open to that conversation. Maybe other doctors wouldn't, but do you think that would be useful? Do you know any doctors who've had conversations with their patients like that? Or
yeah, no, I think that's great. I mean, it is further downstream, and so I mean, there's work that you could do further upstream in terms of looking at neighborhoods that are predominantly Black and figuring out how to help fuel investments, or helping to change the conditions in those neighborhoods, whether it's planting trees, helping advocate for traffic calming measures, that sort of thing. But I think healthcare in general, when you look at the data in terms of patient experience between people are Black, people are white, there's huge disparities there. So I think it's a good idea just to see, have you surveyed your patients who are white compared to your patients who are Black, like left that variable on their patient satisfaction surveys, and how do you do, and is there an opportunity to work on reducing discrimination that may be subconscious or conscious. So I think that those are all good ideas.
Thanks. And Pat's got a hand up, and then there are a couple more questions in the chat. But we'll go to Pat first.
This is more of a comment. I had surgery in Cleveland a few years back. One of the things that they gave me on the way home was a prescription of oxycodone, which I didn't take because I refused to take that stuff. But I was back in 4 weeks for a post-op checkup, and he mentioned that I don't take that stuff, and he said, well, the doctor said, well, give it to one of your friends. And I just you've got to get the word out to the doctors. They can't say stuff like that.
Mm-hmm.
Yeah.
Yeah, well, anytime you hear something like that, I mean, you know, if it's part of a healthcare system, I would call the ombudsman, and it can be anonymous. You know, you're concerned, but it's definitely
It
taken
was
really
just the,
seriously.
it was just the casualness.
Right,
That's,
exactly.
you
Yeah,
know, like, oh yeah,
definitely.
that's what we always do.
Hmm.
Thank you.
Yeah,
Okay,
and
next.
Hmm.
yeah, great. Yeah, the question about are other equations used in the medical field, like the kidney function equation, that use race as a variable? Yeah, there are countless equations that use race as a variable.
I can believe it.
Yep. So the work is just beginning.
And another question from Carolyn: what do you think about wealthy people moving into poor neighborhoods?
Yeah, it's interesting because, you know, I mean, definitely the answer, one of the answers to the problem of structural racism policies leading to segregation, leading to bad conditions and predominantly Black neighborhoods would be integration. Black people moving into, you know, predominantly white, wealthier neighborhoods, and wealthy people moving into Black neighborhoods. So I think that is a solution. And obviously, it gets a bad rap because of the term gentrification and people getting kind of kicked out of their neighborhoods. But when you look at cities across the country, gentrification, to the severe degree that it gets a bad name, is pretty isolated to some of your coastal cities. You know, you look at San Francisco, and like there are no Black people in San Francisco anymore. Just the way things, the demographics have shifted there. But other cities, well, like a micro neighborhood or a small neighborhood might get gentrified. People aren't, you know, having to move an hour away, and it's not the same negative effect. So I think there is a balance there where, you know, it can be helpful for wealthy people to move into poor neighborhoods. And certainly, you know, what we're trying to do is both. Help wealthy people move into neighborhoods that have been underinvested, but also help to build generational wealth, community wealth in those neighborhoods, so people can stay if they want to stay.
Yeah, it's interesting that the city of Buffalo has seen population declines for I don't know, 60 years or something, up until the last census, when the first uptick in Buffalo's population happened in the, you know, the decadal census for the 2020 census. And that is what you might call gentrification, but it is bringing investment into the city. And, you know, if wealthy people, or, you know, not impoverished people move in, then the infrastructure gets better, and but it is certainly complicated.
Yes, it is.
Yeah. And another comment in the chat is infant mortality is another striking example of structural racism. You want to comment?
Yeah, how it played like an outcome from structural racism, absolutely, and that's one of the main drivers, and life expectancy differences as well, because you know, an infant dying in the first year of life will certainly bring down your average life expectancy. So the Black infant mortality in Cleveland is 16 per 1,000 births, and the white infant mortality is like 3 per 1,000 births.
Yeah, if I remember right, the white infant mortality is higher in the US than in most other industrialized countries. Am I remembering right?
Yeah, I'm sure that, yeah, it wouldn't surprise me.
Yeah. Do you want to comment on insurance at all, and the nature of health insurance in the US, and how that plays out along racial lines?
Yes, it's a problem. Yeah, I mean, you know, I would say that you know, a lot of the emphasis historically on life expectancy, you know, even during the COVID pandemic, has been on healthcare expenditures and access to healthcare. But when you and everybody's seen these maps of, you know, we spend way more on healthcare to get the life expectancy, you know, that we get, which is shorter than in other countries, and declining at this point. But when you add up healthcare expenditures plus social services expenditures or human social services expenditures. Every other country, that in the top 35 spends more than us. So whereas healthcare, might be only half of that spending, but you add that social services, they spend more than us because we spend so little on things like welfare programs, universal food programs, universal maternal visiting programs, things of that nature. And so at this point, at this stage of my career where I'm more concerned about that disparity and investment in humans altogether, and less of like the disparity in how healthcare has affected life expectancy, because it seems like that other chunk has a much bigger impact on quality of life and life expectancy.
Yeah, I think we talk about health care a lot of the time when we should be talking about wellness, and those aren't the same thing.
Right.
And another question from Carolyn, is hostile architecture related to public health?
Yeah, I think so. I think certainly the hostile, and when Uncle Pat was at Cleveland Clinic, it's you look at the way, so that monstrosity complex Cleveland Clinic is located in the neighborhood in Cleveland with the lowest life expectancy. And it's a definition of hostile architecture because it's completely inaccessible to the community. There's no walking paths from the community into the grounds of the Cleveland Clinic. And they're hearing this feedback, they're going to work on it. But that contrasts that with what our safety net hospital system is trying to do. Metro Health, they're building a hospital in the park, so they're connecting to the towpath, which is the trail that kind of runs, all the way across the state. They're building a park with the community, with neighborhoods. It's meant to include recreation programs that involve all of the neighborhoods. So it's definitely the newer movement in healthcare architecture and other architecture in general to be more community facing and more accessible to people and pedestrians.
Yeah, and that again is helpful for climate and energy issues as well, which is interesting too. Other questions, comments? Thank you, David, for another our third annual visit from you was again great. It seems like people have quieted down with their questions, so I put a couple of links in the chat. If you enjoy this program, there's a link to donate to help support it, and the link for the events page for Science in the Virtual Pub is there as well. And a nice thank you from Lisa in the chat. And I'm certainly game to stick around for a while if people want to stick around for a little bit and ask more questions, but perhaps we're done with the formal program.
I have a question for the speaker.
Yes.
So
go ahead.
Is the city looking to maybe rebalance its budget to emphasize these priorities and maybe shift away some funding away from public safety, say, and more towards public health, more towards parks and recreation, things like that?
Well, I think we definitely want to rebalance it, but we're not going to take away any investment from police right now with the vacancies that we have and the homicide rate where it's at. So the hope is that we can increase the investment on the other side, but I can't see a situation where they would be able to take away, any of the current police given the, state of things right now.
Does spending on police really have much to do with the homicide rate?
Well, I think that we all know the answer to that, but unfortunately, there's just not a political path to do that.
Right. Yeah, it's interesting. I was in another meeting earlier today about the resilience of the educational system to needed change. And I think the resilience to the policing system or public safety or whatever label you want to put on that sector of society is similar, as is the resistance to change in a lot of the healthcare system.
Yeah, exactly.
Heavy sigh.
Right, exactly. I mean, it's right. Healthcare, it's the same thing. It's like we don't need as many specialists as we have, but you take away this, but I mean, it's all the same. Yeah, challenges. So we'll work on it. I think, my goal is to put them all out of business. There is just an example of all these different things. There's a randomized trial that came out that showed if you look at homes like the home that I had the picture of, and you rehab homes in pocket neighborhoods and don't do anything in other neighborhoods, the crime homicide rate went down in those neighborhoods where the homes were rehabbed, like the broken windows theory type of thing. So that's what we're going to keep doing, and hopefully we'll put them all out of business.
Yeah, and there's interesting stuff going on in Buffalo that I assume there are similar things in Cleveland as well. People push Buffalo as People United for Sustainable Housing, where they engage kids in restoring dilapidated homes, and the Massachusetts Project is another one that, and those folks know each other and do some really great work, which hopefully can spread.
There is a cable show, which Carolyn should come up with the name, where these guys in Detroit go into horrible neighborhoods, buy beat up houses, and get them back into great shape. And one by one in a neighborhood, they make it better. And that brings in money, because people who can afford the house can afford more. And it works.
Yep. Yeah, the area around Buffalo in general is not so pretty either. Be interested to look at the relationship of major hospitals to their neighborhoods.
Yeah, I mean, we had a few hospitals close in Cleveland area, and folks wanted me to write a letter saying, don't let the hospital close, it's bad for health. And I said, I think it might be better for health if that hospital closes. So I will not be writing that letter.
Well, thanks again so much. Any other closing comments?
This is Trisha. Thank you for this. I work for a large New York City-based health organization, and I see it all the time. And, end of life care, and that's another really sad thing to think about, people not accessing and not getting the care while they're living, but also while they're dying is pretty horrific. So I know we're working on that in our organization. So thank you for this.
Thank you.
And Trisha, Dave, Trisha.
Oh, great.
I was
nice
I was
at
your family for Christmas.
Oh, yeah, great. Wonderful.
I'm turning red again.
Be done good.
Yeah. All right. Well, thank you one and all, and see some of you in 2 weeks for talking about science and religion. Good night, Lisa. Good night, all.
Thank you.
Thank you.
David.
Thanks. Bye.
Bye.